section is on organic disorders for behavioral science and psychiatry for Falcon Physician Reviews. So you will see that we're going to look at the lobes of the brain in the next couple of sections. First of all, we'll talk about the frontal lobe. So the frontal lobe is associated with motivation, inhibition, concentration, attention, and executive functioning. What executive functioning is the ability to pay your bills, to drive a car, to cook, these kinds of things that needs a higher level of thinking. So if you have a lesion in your frontal lobe, then you'll be disinhibited, meaning that you won't be able to think before you do things. You'll do very impulsive things. You'll have lack of emotion or lack of motivation, where you'll be very apathetic. It'll be difficult to concentrate, and it will be difficult to perform your routine daily tasks. People have also noted to have mood disorders because of frontal lobe disorders, such as if you hurt your left frontal lobe, it is found that more people have depression, and if you hurt your right frontal lobe, people have noticed to have more bipolar disorder. Also, Broca's area, which is your motor area for speech, is located in your frontal lobe. So if you have a lesion in your frontal lobe, you will be able to comprehend what other people say, but you'll have a very difficult time expressing what you would like to say. Therefore, it's called Broca's aphasia or expressive aphasia, or it's a motor aphasia. Next, we have our temporal lobe. And if your temporal lobe is impaired, you'll have an impaired memory, difficulties with learning as it involves your hippocampus, and you'll lose the ability to recognize objects, and this is known as visual agnosia. Now, in the temporal lobe, we have Wernicke's area, which is your area for speech in which you comprehend. So if you have a lesion in your temporal lobe, then you will not be able to understand, but your Broca's area will still be intact, so therefore you'll have very wordy speech which will not make any sense. So hence this would be a sensory aphasia or a very fluent aphasia. Next, we have the parietal lobe, and the most important thing for you to remember in the parietal lobe is that if you have a lesion in the non-dominant side, you will have neglect of the contralateral side of the body. Also, though, the parietal lobe is very important for visuospatial processing and also for processing of verbal information. So if you have any lesions there, you will have impairment in both of these areas. The occipital lobe is associated with your visual cortex. So if you have a lesion there, you'll have visual hallucinations and blindness. So next we'll talk a little bit about dementias. Now the main feature of all dementias is there is an impairment of memory. But not only do you have to have an impairment of memory, but you also have to have at least one of the following four. You either have to have aphasia, apraxia, agnosia, or impaired executive functioning. So with aphasia meaning difficulty using words, impairment or difficulty in comprehending your words. Apraxia means that you have a normal motor system. Your reflexes are intact, your strength is intact, but you're not able to use your motor system very well. So it's a volitional motor disorder. And how you'll check for that is you'll ask the patient to show you how will you brush your teeth or how will you comb their hair, and they will have a very hard time to do this. Then you'll have agnosia. So in agnosia, the sensory system is intact. Their sense of touch, their sense of pressure is all intact, but if you give them something to put in their hands, like you give them a key, they won't be able to recognize it. And executive functioning, they'll have a very difficult time planning, sequencing, initiating things. So you have to have memory as well as one of the four that we just discussed. So about at the age of 65, 15 to 20% of people will develop dementia. And as your age increases, so does the percentage. So people above the age of 80, generally about 45% of people will have dementia. These numbers are important for your exam. They are high yield points. Now, 15% of dementias are reversible, and these are usually due to some kind of toxic exposure, or sometimes right following a stroke, some people have some difficulties with memory, and eventually through physical therapy, and as the stroke resolves, sometimes they will improve. 60% of dementias are due to Alzheimer's dementia. This is the most common kind of dementia. So on your exam, if they give you a dementia question and you can't figure it out, you have no clue what they're talking about, answer Alzheimer's dementia because it is the most common kind of dementia and you have a good chance of getting it right. The second most common is going to be due to cerebrovascular disease. It's also called vascular dementia. So there are multiple different types of etiologies for dementia. You have vascular, anoxic brain injuries, infections, degenerative, demyelinating, and metabolic. Also have toxins including insecticides, heavy metal, alcohol, tumors, as well as trauma. So what are cortical dementias? Cortical dementias are associated primarily with memory deficits, aphasia, and problems with calculation. Cortical dementias will have much less motor deficits. And an example of this will be Alzheimer's dementia and Pick's dementia. These are the only two types of cortical dementias. So if you can remember your cortical dementias are Alzheimer's and Pick's, then everything else is subcortical. And remember that these people will have a primary deficit in their memory and difficulty with their speech. And an example of this with the Alzheimer's patients is that if you give them 3 words and you ask them to repeat them, they can pretty much recall those 3 words immediately. But if you ask them in 5 minutes, can you tell me those 3 words I asked you to remember? They'll have a very difficult time, even if you give them clues, to remember them. And frequently these patients with Alzheimer's dementia have a very difficult time encoding this information into their brain, and hence their memory is severely impaired. Next, we have the subcortical dementia, which means that the dementia is affecting deeper parts of the brain. And these guys, their memory is not as impaired as it is for the Alzheimer's patients. And they will have more difficulties with planning, apathy, gait, and other motor abnormalities. So if you notice someone with some kind of a physical abnormality, first think about a subcortical dementia. But if you see someone with a memory problem significantly and a bad language problem, then you're going to think of a cortical dementia. Types of subcortical dementia include Huntington's, Parkinson's, normal pressure hydrocephalus, multiple sclerosis, and AIDS dementia. Again, Alzheimer's dementia is your most common type of dementia. What are some risk factors? Your age. It's usually more common in women than men, just slightly more. And there's a significant family history. Also, most of these patients will have an ApoE4 allele, but we really don't recommend that you screen people for this, but they have found that patients who do have Alzheimer's dementia will generally have an abnormal ApoE4 allele. And also, in Down syndrome, most patients who live to the ages of 40 to 45, 95% of these patients will have Alzheimer's dementia. So again, if you have a very young person who develops Alzheimer's dementia and they want to know what the comorbid condition is, consider Down syndrome. So what does the brain of a patient with Alzheimer's dementia look like? Well, you'll notice atrophy that is out of proportion for the age in the brain. Also, you will notice that there will be ventricular enlargement. And the temporal lobes will be more affected than other lobes in the brain. Microscopically, you will notice amyloid plaques and neurofibrillary tangles. And the neurofibrillary tangles will contain tau protein, and this is a high yield point for you on your exam. Now, how will you remember tau is in tangles? Well, they both start with T, so that's a good way to remember the two of those. Also, the more presence of the tangles, the more severe that the illness is. Now, you wouldn't notice this on a person who's alive. You wouldn't do a brain biopsy to see if they had neurofibrillary tangles. This is all done postmortem. Neurochemically, though, the reason why you have these deficits is they've noticed that there's loss of cholinergic neurons in the amygdala, the hippocampus, and the temporal lobes. So if you have decreased amounts of choline acetyltransferase, then you have decreased amount of choline in your acetylcholine in your body. So how do you treat this? You give them acetylcholinease inhibitors. So how does this help? It helps to prevent breakdown of acetylcholine, so therefore there's more acetylcholine in your brain. What does Alzheimer's dementia look like? Again, patients having difficulty with their memory, having speech problems, and it's a very gradual process. Usually family members will overlook it for a couple of years and they'll say, you know, doc, I've noticed that my dad's just really slowly been progressing like this. He's slowly forgetting things. First it was just, oh, I just forgot this, I'll go back and get it, but now he's not remembering names and it's just progressively getting worse. So it's a very, very slow progression. And your cognitive symptoms like your memory or attention typically precede your behavioral symptoms, and death usually results in about 8 to 10 years. So how do you treat patients with Alzheimer's dementia? First, you have to have education for the family. One, you have to label the rooms because these patients frequently get confused. Sometimes they'll leave the house thinking that they're going into the kitchen. Also, as they progressively get more and more demented, they will lose their ability to make decisions. So you want to put someone in the family to be their power of attorney or guardianship to help make their decisions because they're not going to be able to make very good decisions about their health care. Pharmacologically, we have medications called acetylcholinesterase inhibitors. And examples of these are donepezil, which is Aricept, rivastigmine, which is Exelon, and galantamine, which is Remenel. And what these do is they do not cure the illness. So that's the first point that you have to let the family know. Basically what they do is they help slow the progression of the disease. The disease will continue to progress even if you take these medications, but it might just slow it down for a year or two. Antipsychotics can be given with aggression and psychosis, but you must be careful because the atypical antipsychotics actually have a black box warning that they can cause sudden death in patients with Alzheimer's dementia, or any kind of dementia for that matter. Also, a newer medication called memantine, which is an NMDA receptor antagonist, is now on the market. And this is for more moderate to severe dementia. So after you've tried the acetylcholinesterase inhibitors for some time, you've noticed some improvement, but the dementia is getting worse, then you can add memantine, and that is also shown to kind of slow the progression of Alzheimer's dementia. And you want to give them supportive care such as food, hygiene, etc. because they can become very apathetic, they won't know how to take care of themselves, frequently need a lot of assistance. Next we'll go on to vascular dementia, more common in men, usually around the ages of 60 or 70, and frequently these guys will have high blood pressure, there'll probably be some history of stroke, they'll have some kind of paralysis or some kind of neurological deficit in your history. You'll notice, oh, they're having a little bit of difficulty walking, and that will help you differentiate this from an Alzheimer's dementia or a cortical dementia. This is very different from Alzheimer's in that it's very sudden in onset. Family members will usually bring in their vascular demented family members much earlier than an Alzheimer's dementia because Alzheimer's dementia is very subtle, it's very progressive. Whereas with vascular dementia, it's a very obvious sudden onset. And they have a stepwise progression, which means that they're doing well for some time, and then they have a sudden drop in their functioning, and then they do well for a little bit longer, and then another sudden drop. Again, remember that there will be focal signs with deficits in either the motor or sensory areas. Next, we have Parkinson's disease, and it is found to be prevalent in about 200 in every 100,000 people. That's not an important number for you to know, but just for your information. Usually onset between the ages of 50 to 60, and 40% of people with Parkinson's disease will eventually develop dementia. And what will you notice in the brain if you have Parkinson's disease is you will notice the degeneration of neurons in the substantia nigra. You will also notice Lewy bodies in the brain, and specifically in the substantia nigra. They will not be found all over the brain. And the brain loses the ability to convert tyrosine into levodopa. So Parkinson's disease is a disease of decreased dopamine. So therefore, what are the symptoms of decreased dopamine or Parkinson's disease? You'll have a tremor, and it's a very characteristic tremor. It's a pill-rolling tremor, usually resting. If you ask the patient to move, the tremor will decrease. Also in Parkinson's disease, the tremor will go away when they're sleeping. They will have cogwheel rigidity, bradykinesia, which means that they will move slowly, mask facies, so they will look like they have very flat affect, they look very depressed. Their gait is very, very interesting. It'll be a shuffling gait, and it's called festinating, which means that they will take very, very short steps and they'll continue to accelerate. Very characteristic for Parkinson's disease and very high yield for your exam. If they ask you where do you see a festinating gait that's shuffling, then that will be Parkinson's disease. There will be decreased arm swing, meaning that when people walk, they move their arms side to side. Well, patients with Parkinson's will keep them right next to their bodies. They will have micrographia. So as they're writing, their handwriting will get smaller and smaller, and frequently depression will be comorbid with these patients. So how do you treat these patients with Parkinson's disease? As we said before, Parkinson's disease is a disease of decreased dopamine. So you want to increase the dopamine in their body. So there are different types of medications that you can use. You can use medication to promote release of dopamine, which is amantadine. You can use dopamine precursors such as levodopa. And levodopa is frequently given with carbidopa because if you give levodopa by itself, then you get a lot of peripheral side effects as well as it's used up in the peripheral system before it gets to the brain. So carbidopa helps so that it can get to the brain and be more effective. Also, you can give dopamine agonists such as bromocriptine or ropinirole. Monoamine oxidase B inhibitors, and how this helps is that it prevents the breakdown of these monoamines. And an example of this will be Selagiline. And then also you have catechol-methyltransferase inhibitors. And again, this is another enzyme that breaks down monoamines in the synaptic cleft, and tolcapone and entacapone are useful because it increases the dopamine levels. Next we have Huntington's disease, which is a very high yield disorder for your exam. You must remember that it is an autosomal dominant condition, and it's due to a trinucleotide repeat, and it's a repeat of CAG, so that is also important. You must know that it is a repeat of CAG, and it occurs on chromosome 4. And the more trinucleotide repeats that you have, the earlier that you will get it, and also the more severe that you will get it. Males are equal to females, and generally you'll get it around the ages of 30 to 40. There is noticeable atrophy of the caudate nucleus and the putamen, and it usually leads to death within 10 to 15 years. So what you notice with Huntington's chorea is that they have choreoathetoid movements, which means dancing, writhing-like movements that they have very difficult time controlling. They also have a lot of psychopathology such as depression, anxiety, psychosis, and if patients live long enough, a majority of them will have dementia. Pick's disease is our next disorder, and this is our other cortical dementia. It's very rare, and here you will also find a younger male, probably in his 50s, who has new onset personality changes, who has memory problems. And it's a cortical dementia, but it much more affects the frontal lobes than the temporal lobes as in Alzheimer's dementia. So if you notice someone who they talk to you in a vignette about much more frontal lobe syndrome, then look for a Pick's disease. A lot of personality changes, and what you'll notice on histopathology is intraneuronal inclusions or swollen neurons. And these intraneuronal inclusions are called Pick bodies. Next we have dementia with Lewy bodies. And this is also another very common form of dementia, thought to be about the third leading cause of dementia. Now this is a dementia that you might get confused with Parkinson's dementia. And how you can differentiate the two is that a patient with Parkinson's disorder will have the movement disorders, the Parkinson's disorder first, then it's followed by the dementia. But a patient with dementia with Lewy bodies, both of these symptoms will come at the same time. Also, a Lewy body dementia, they will have more visual hallucinations, and they will be very, very sensitive to antipsychotic medications. Also, if you were to look at the histopathology of a patient with dementia with Lewy bodies, the Lewy bodies will be scattered all over the brain, whereas in Parkinson's dementia, you only see Lewy bodies in the nigrostriatal area. Our next disease is Creutzfeldt-Jakob disease, and this is another high-yield question on your exam. It's a spongiform encephalopathy which is caused by a prion disease. It's rapidly progressive. It's usually fatal in 2 years or less, and really more frequently in 6 months or less. People will get dementia, hypertonicity, myoclonus, And in a very important point on your exam is they will explain a patient with Creutzfeldt-Jakob, and they'll give you the EEG changes. So if you can recognize the EEG changes, which is a slow, irregular, periodic complex discharge, you'll easily be able to get this question right. Next we have AIDS dementia, and as patients are getting more and more treatment, we really don't see AIDS dementia as commonly. And prior to retroviral treatment, you actually saw it in about 60% of patients, but now it's only in about less than 10%. And what you'll notice is they have very much so problems with attention. Attention is the main thing that AIDS dementia patients will have a problem with, followed by other memory problems and other cognitive problems. Now, how do you treat this? If you put them on an antiretroviral treatment, the dementia actually will improve within 6 months to a year, and the patient will do very well. Normal pressure hydrocephalus. Now, this means that there's too much cerebrospinal fluid. How will you be able to identify a case of normal pressure hydrocephalus on your exam? Well, there's an easy mnemonic. It's called wacky, wobbly, and wet. So there are 3 W's. So dementia is the wacky, wobbly is the gait disturbance, and urinary incontinence is the wet. Now generally the urinary incontinence will be the latest, and you'll get that in the long run, but the first signs you will see will be the dementia and the gait disturbance. On a CT or an MRI, the ventricles will be very enlarged, but there won't be that much cerebral atrophy, so that will be how you'll differentiate it from other kinds of dementias. And how will you treat this? Treat it with a shunt, and that usually is therapeutic. Next we have Wilson's disease, which is an autosomal recessive disorder on chromosome 13. Again, this point is very important for your exam. It is a very important high yield point, and it is due to copper accumulation. How do you treat it? You have to restrict copper, and you give chelating agents such as dimercaprol and penicillamine. But how will they present a case of Wilson's disease to you on your exam? So frequently you will actually be a young person, maybe an older adolescent, someone in their 20s, who comes in and they will mention that they have a green circle around their cornea, and also that their liver is enlarged, and they have some neuropsychiatric symptoms such as problems with their memory, they're depressed, or they're manic. And what is the cause of this disorder? So your answer there would be Wilson's disease. Next, we're going to talk about multiple sclerosis, and this is frequently found in females and also common in temperate climates versus more tropical climates, and generally starts in the ages of about 20 to 40. CSF findings, which are very high yield for your exam, are your oligoclonal bands and your myelin basic protein. So what does MS do? It attacks the myelin sheaths of the CNS, but the bodies and the axons of the nerves are spared. And it has a waxing and waning course, and it's a demyelinating illness, so therefore it impairs the transmission of the neurons. More symptoms of MS, it can only affect one cranial nerve, and that is the optic nerve. So if you have a young female in her 30s with some vague neurological symptoms that don't really fit because they have multiple demyelinating lesions, so they'll have multiple neurological symptoms, and it affects their eyes, where they have very painful red eyes, and they also might have some depression. The first thing that's going to come to your mind is going to be multiple sclerosis. Next, we're going to talk about delirium, and frequently when you're on a psychiatry rotation, especially the consult rotation, the medical team will need some help to differentiate between dementia and delirium. So what delirium is a acute disturbance in consciousness. And the main abnormality in delirium will be a difficulty in attention. And that is going to be the primary abnormality in delirium. They're still going to be able to talk, their probably memory is still going to be intact, but they just cannot focus attention at all. It's very sudden in onset. It fluctuates throughout the day. So for maybe 10 minutes, they're doing really well. They know who they are. They know why they're in the hospital. But then 10 minutes later, they don't know who they are. They're seeing things. They're hearing things. And delirium is due to a direct effect of a general medical condition. So what are the different causes of delirium? You have a mnemonic in your book. It's withdrawal, acute metabolic conditions, trauma, CNS pathology, hypoxia, drugs or medications, endocrine problems, acute vascular problems, toxins, or heavy metals. You can remember that by remembering I watched death. But basically anything can cause delirium. So when you're looking at a patient, usually elderly people are the ones that are most affected by delirium. Look for, well, do they have too many anticholinergic medications on board? Is that what's causing them? Are there any new medication changes? Did we suddenly stop a medicine? What if they had been on a benzodiazepine for a long time and they went into surgery and you suddenly stopped their medicine? Well, they're probably having withdrawal. Or what if a guy comes in, and this is a frequent way they'll ask you delirium on the exam, is they'll have a woman, and you won't suspect this, but she's had surgery, and 3 days later she's delirious, doesn't know where she is. Well, you want to suspect possible alcohol abuse. Maybe she's withdrawing from her alcohol, and that is why she's become delirious. So those are common ways that they'll ask you this on the USMLE. So how are you going to differentiate delirium versus dementia? Well, in delirium, again, it is very acute, starts very rapidly, usually from days to weeks, and it comes and goes. So one day they're doing well, or 1 hour they're doing well, and then the next hour they're not. They can have hallucinations. They're not always there. It doesn't have to be there. It's reversible. You can treat delirium, and it is often, you will also have cardiovascular signs such as increased heart rate, your blood pressure will be out of whack, they might even have a temperature. Now in dementia, that's frequently something that's chronic, it's lasting a long time, and you won't notice the sudden changes. Like if he doesn't know the date today, he's probably not going to know the date tomorrow or the next day. He's probably going to have impairment all the time. It's not going to be that he remembers you today and he's going to remember you tomorrow. And they can have hallucinations, but it's even much less common than in delirium, and most of dementias are not reversible. Next we'll go to traumatic brain injuries. And about 2 million people sustain a traumatic brain injury every year, and about 300,000 require hospitalization. About 5 million children sustain head injuries each year, and 200,000 of those are hospitalized. So bicycles seem to be the main reason why children have head injuries, so therefore it's very important that your child wears a headgear when they ride their bicycles. And about 400 die each year from bicycle accidents. This concludes our